All right, good morning. We're in the small auditorium alone, but we're happy to be here today. I want to speak to you on a topic that I think hopefully will be entertaining and informative for the obstetrical colleagues, particularly those that are delivering babies. Is that working correctly? I believe it looks like it is.
Yes.
Okay. So one thing that I wanted to mention, as Chad did, is as a third-year medical student, Dr. Latif was my intern and on the L&D service in July of her intern year. And she was impressive at that point, but has grown in her clinical acumen over those years. And as Chad mentioned, he was an intern on internal medicine when I was a third-year medical student, and he also has become quite an impressive obstetrician and leader in the department. So thank you for having me here today. And as I mentioned, I'm going to speak to you today on late preterm infants. I think a population that both of us as neonatologists and obstetricians deal with not infrequently, and a population that I think may not get quite the press that some of our more extreme preterm infants do, but probably is a bigger problem, to be quite honest. So let me get started. All right, so no disclosures or conflicts to discuss. So I have three major objectives. The first is to convince you that delivery between 34 and 37 weeks post-menstrual age is a major opportunity for improvement. I also want to convince you that late preterm infants have ongoing health concerns, that this is not a healthy population, and also provide a platform for assessing risk in late preterm infants. And this is more for our pediatric and neonatology colleagues. So I have a little bit of something for everybody, unless you're a gyn-onc. I don't think I have anything for gyn-onc. So late preterm infants. So Bill Engel, who composed this opinion piece, was my clinical mentor at Indiana as a fellow, and he was really the father of this sort of nomenclature. And so for many of us, this is very common knowledge, but I think sometimes we forget exactly what defines this late preterm population. So anything born before 37 completed weeks is considered to be preterm, and we hone in on the late preterm as being 34 completed weeks up to just a budding 37 completed weeks. This population generally delivers. Sorry, I'm getting some feedback. If you could mute your microphone.
I kind of had a sneaking suspicion. He doesn't believe me, but I feel like I always
We'll keep going.
So I had no idea, and I was like, I don't know, but he called me from
the difficulties of virtual presentations. So the distribution of preterm births in the U.S., our latest data is from about 2013. As you can see here, if we take all preterm births, approximately 70% of those are born between 34 completed weeks and just up to 37 weeks. And to be quite honest, the vast majority of the press is below 32 weeks, what we call sort of our very preterm or extremely preterm population. And so, which composes about 25 to 30%. So in reality, this is the much more common preterm population, and it really doesn't get a lot of research or press. And let me outline to you exactly what that means in hard numbers. So if you look at the Centers for Disease Control, they publish each year some annual statistics on births in the United States. And as you can see here, this is by percent, and you can see early preterm of all births makes up about 2.75%, and then all preterms make up about 9.85%. So about 10% of babies are born before 37 weeks. But that also means that about 7% of these preterm, of all infants born each year, are about 34 to 37 weeks and considered to be late preterm. So it's not an insignificant population. And what's really interesting too, and particularly true of where we are in Augusta, that there's a race discrepancy between late preterm delivery. So if you look at late preterm, and I've kind of outlined this in the red box, for all the whole population, roughly 7%, as I mentioned. And you can see sort of this U-shaped distribution, so that the younger you are, like 15, about 8% of pregnancies, and then the older you are, 45 to 54, about 15% of those moms will deliver preterm, or excuse me, late preterm. And as you might expect, Caucasian mothers have a lower incidence of delivering late preterm. So the overall population delivers at about just under 7%. When you look at this for African Americans, it's much more astounding. So all African Americans deliver on average almost 9% in this late preterm population, and you still get this slight U-shaped distribution, but it's not even close to what you see in the Caucasian population. So if you compare, say, the prime ages for delivery, like the 20 to 30-year-old, you're still running north of 8% of all births being late preterm. And this is not true of the Caucasian population, where you're almost approaching the low sixes. So I just think that obviously race discrepancy plays a role in late preterm birth, which, as you guys know, has to do a lot with prenatal care. It has a lot to do with antenatal care before they get pregnant. There's a lot of complexity here, but it does sort of show you that there's about a 33% relative risk increase for late preterm birth in Black mothers. And so just this from the CDC also highlights this. If you look at these populations, these are absolute numbers and rate per 1,000 for 15 to 19-year-olds. So these are mostly moms that we would rather not deliver. I guess at 19, it's not considered unhealthy, but we'd like to limit teen pregnancy as much as possible. And I know you guys are passionate about that, but the rate for Caucasians is decreasing, as it is for all populations over these couple of years. But you're still looking at about 14 to 15 per 1,000 for Caucasian mothers. And then when you go to the Black population, it's double that. So this is a particularly vulnerable population. Our teenage African American mothers are delivering at high rates of late preterm infants. And you can see that I didn't mention Hispanic mothers, but they parallel that quite well. And just to go back and reemphasize this again, you can see these race discrepancies, and they hold true for not only African Americans, but several other minority populations. I just know that our birth rates of African Americans is our predominant, quote unquote, minority population, even though African Americans are a majority population in Richmond County. So this puts Georgia 7th in the country for late preterm births. 7th. So as you might imagine, most of the late preterm births occur in the Southeast. Georgia definitely does a better job than Mississippi. It does a better job than South Carolina, but we definitely struggle compared to most of the other states. And this graph from the CDC, I think, is very informative. So this shows the percent of preterm births in 2005, and you can see that over here on the left side that there's rates per 1,000 on average about 12.7, and you can see, or sorry, percents, and you can see that Georgia is not the worst. It's certainly not in the darkest blue, but it's certainly not in the sort of greenish or tan color. And then we move ahead to 2016, and you can see that while the overall rates of preterm birth, if you're looking at those two left columns, the top column refers to the 2005 data, the 2016 data is in the bottom column. So you can see that nationally the rates of preterm birth have diminished, and that's a success nationwide. But Georgia, in fact, relative to the rest of the country, has not improved at the rate that some of the other populations or states around the country have. And so just to give you some more absolute figures, here's Georgia looking at a birth rate of roughly 12.6. And you can see here that we still have a significant population of teenage mothers, 15 to 19, who are delivering babies. And that particularly in the African American community is a population at risk for, even if they have a healthy pregnancy, of delivering at late preterm gestational periods. And we just believe, and I think I'll show you the evidence, that that's just not truly a healthy population. So Colorado got a lot of press a few years ago about their programs to sort of stave off unwanted pregnancies. And I just clipped this from the New York Times. 2015 article, and it says, over the past 6 years, Colorado has conducted one of the largest experiments with long-acting birth control. And if teenagers or poor women were offered free intrauterine devices and implants that prevent pregnancy for years, state officials asked, would these women choose them? And in fact, they did. The results were startling. The birth rate among teenagers across the state plunged by 40% from 2009 to 2013, while their rate of abortions fell by 42%. I mean, that's a win for all parties who are invested in both teenage pregnancy and abortion rates. There was a similar decline in births for another group particularly vulnerable to unplanned pregnancies, unmarried women under 25 who have not finished high school. And we can all agree that this is a population who we want to, if they're not ready to have babies, we want to help them avoid getting pregnant in the first place. So going back to Dr. Ingalls' publication back in 2009, I believe, this is the paragraph that I thought was the most insightful. So infants born at 34 to 36 and 6/7 weeks gestation, or termed late preterm, are often the size and weight of some term infants. And I think that's the key ingredient for why they may be prone to being ignored. So they often are the size and weight of more term infants. Because of this fact, late preterm infants may be treated by parents and caregivers and healthcare professionals, I'm speaking to mostly my pediatrician colleagues, as though they are developmentally mature and low risk of morbidity. They are often managed in newborn level 1 basic nurseries or remain with mother after birth. Late preterm infants are physiologically and metabolically immature. So they disguise themselves as term infants, but in fact are not term infants. And so let me just highlight why this is the case. So if you look at, these are growth charts for infants, and based on gestational age on the x-axis, and then weight in kilograms on the y-axis. And I have a boys chart and a girls chart. And I know that OBs hopefully don't look at this too much. But if you look at 34 weeks, right, so the 50th percentile, the average birth weight for a 34-weeker should be somewhere around 2.2 kilos for a boy and about 2.1 kilos for a girl. And if we go all the way up to 37 weeks, what I've done is shown you that the average birth weight for a 37-week infant is just under 3 kilos for both boys and girls. So that weight alone sort of puts you in a category where you can, stay with mom and sort of do most of the normal physiology and transitioning. In fact, our cutoff here for low birth weight admission to the NICU is 2,300. So you could argue that, 70% of these kids born between 34 and 37 weeks may be eligible to avoid a NICU admission. And so if we take sort of a flat cutoff, a lot of NICUs have an admission threshold of about 2 kilos, which is, low birth weight is 2.5 kilos, but 2 kilos is sort of a magic number. If you're below that, you almost certainly need some support, that's going to require a NICU stay. That sort of puts you for boys somewhere around the 30th percentile, and at 37 weeks around the 2nd percentile. Similarly for girls. So you're talking about a vast majority of the population here that can sort of sit in what is considered to be a normal nursery. And so let me transition here to talk about their risk. So this graph I extrapolated from a publication in Pediatrics from 2009, so a little bit dated, but the trends will be highlighted here. So the red line is the infant mortality rate, which is deaths under a year, and the neonatal mortality rate in the blue, which is deaths under 28 days. And you can see these lines match each other quite well. And as you might expect, the smaller or more immature the baby, the more likely they are to die in the first 28 days or the first year of life. But when you subtract these two, you sort of come up with what's a rate of death after 28 days. So between 28 days and 1 year of life. And the nice thing about this graph is that it sort of removes all the kids that die because of perinatal causes. So these are usually late deaths, right? So kids that sort of survive the NICU, particularly when you're talking about, 34 to 37 weeks, and you still see a rate of almost 5 deaths per 1,000 for babies born at 34 weeks and surviving the first 28 days. And that rate declines significantly, but even at 37 weeks, you're looking at a twofold increased risk of death after 28 days and before 1 year of life up to 37 weeks. So it is a vulnerable population. I think there's no question about it. And so I'm on my soapbox. I'm going to stay on it for just a minute to highlight a couple of other concerns. So if you look at infant mortality rates for selected countries, and these are all relatively first and second world countries, the United States, the rates of preterm or the infant mortality rate per thousand births roughly is 6.9 or 7 per thousand. And this is data that was from 2018, so not too distant past. And, the best countries in the world are running about 2 per thousand. So for a developed nation, we have some strides to make. And I know this data is not clean. A lot of countries don't report, certain gestational ages. But if we sort of remove anything less than 22 weeks, we start to get at least on some even playing ground. And the United States still lags behind. Countries that, have what I would consider relatively poor healthcare systems like Greece. And even though what's interesting too is that life expectancy usually mirrors this infant mortality rate. And there's obviously overlap with those two numbers, but the better our adults live or our older people live or the longer they live, usually infant mortality sort of mirrors that rate for a number of reasons. And then if you look at the percentage of preterm births in the United States versus a lot of our similarly matched countries, we are astoundingly, on at least in this data from the CDC, astoundingly lagging behind most developed countries. Let me show you in a different manner and why I think this data requires a little bit of interpretation. So I took this from data briefs from the CDC, and what I've done here is looked at about 10 countries that I would say are not dissimilar from the United States for which there was data, and basically looked at infant mortality per thousand at various gestational ages. And I tried to sort of pick out a yellow for gold, which is Sweden, a silver for Norway, and a bronze for the United States based on, sort of the Olympic medals. So you can see here with the extremely preterm infants, those born less than 28 weeks, we do pretty darn well. Our rates of mortality are better than most. We're looking at less than 28 weeks or 24 to 27 weeks that our mortality rate per thousand is about 24%, which is pretty good. We're only lagging behind Norway and Sweden, both of which have a more homogeneous population and have national healthcare systems. And even at 28 to 31 weeks, we're still doing pretty well. We're sort of in a second bronze. We just are a fourth place finisher in that regard. But what's funny is when we transition into what should be the bulk of our pregnancies, and particularly this population that includes the 34 to 37 weeks, we start to fall apart. So you can see that we're not the worst by any stretch at 8.6 per thousand, but we're still lagging behind some other countries like Austria sort of surges. Norway is still doing well, and Sweden has a very similar problem. And then when you get to term, right, we still struggle. So our mortality rate with term infants in some respects is 50% higher than other developed countries. So, we've done a lot of work trying to get the mortality rate and survival for these extremely preterm infants down, and we've been successful largely. But it's really time for us to transition our focus onto the vast majority of the population. And I think there's a lot of calls in the pediatric and obstetric literature to that this is an opportunity for us to really make an impact on outcomes. So let me transition to something that a lot of people care about, which is cost. And so as you might expect, cost is pretty significantly inversely related to gestational age. So the lower your gestational age is, the more we spend in total healthcare dollars. So you can see here, I've just highlighted 34 weeks to term, and you can see that the cost per in US dollars stretches up $125 million for 34 weeks and comes down all the way to about 40 million in 37-week infants. And so what's interesting is when you look at total healthcare costs per couplet, so this is mom and baby, what I've done here is shown you mean and median because this is all skewed data, right? So if you look at these 24-weekers, they're going to cost a tremendously amount more. The moms are usually sicker, which is why they're delivering at 24 weeks. So it's hard to sort of, if you keep going back, you get some really skewed data. But what I wanted to highlight here was that if you just move the needle 2 weeks, right? So from 34 to 36 weeks, we see over a 250% cost savings in couplet care in total healthcare expenditure, and that works still out to 36 weeks. So if we move our 36-week infants to term, we can see a 30% reduction in couplet care costs. And this holds particularly true for the neonate who's, obviously has a NICU stay almost invariably at 34 weeks. So if we move the needle from 34 weeks to 36 weeks, we see over 1,000% drop in healthcare costs for the neonate. I mean, that's astounding. I'm sure, I didn't do the math, but I'm sure that if you moved it even just a week, it'd be a 500 to 700% drop. And what's also interesting is if you look at the cost in another way, which is per day of care, it's still very, very expensive to have a 34-week infant compared to a 36-week infant. And as you can see, at 36 weeks, the cost per healthcare day is about the same as a term infant. But at 34 weeks, it's over twofold difference. So it's expensive, right? So if for no other reason, healthcare entities should be emphasizing late preterm births because they want to save money. And we have to find common ground at which to attack problems. And I think administrators love to save money. So that's an easy one to sell. And then we know that late preterm births, I didn't even touch on this, like NICU admission, right? Respiratory distress syndrome, invasive ventilation, jaundice, low sugar, temperature issues. There's a whole risk of issues related to late preterm births. A particularly expensive one is hospital readmission. So if you're born late preterm, you have about a 5 to 7% risk of readmission within the first 30 days, right? So that's an added expense that we were really hoping to avoid. So, the trap is set. So we have these late preterm births, these infants that mimic older term infants, but I think that's the lull before you go to sleep. And so I want to highlight why this population, from a medical standpoint, is a risky population. I'm just sort of going to march through a couple of systems and highlight some key facts of why this population is particularly at risk. So weight gain and length gain, those are key predictors of a number of late outcomes. They are predictors of obesity later in life. They're predictors of cognitive outcome. Obviously, we want appropriate weight and length gains, but we don't want, I think we're hopefully getting away from the idea of fat babies or healthy babies. But what I want to highlight in this article is just that late preterm infants are slower growers, right? So if you look at this population in India, so this is 150 kids in each arm. This is, a reasonably well-controlled study. But you can see that weight gain over the first year of life, length gains, head circumference gains, all lag behind their term counterpart, whether you look at absolute numbers or weight gain as a relative gain from birth weight. What's also interesting is this population is especially needy of breast milk or human milk. So if this is just a complex chart. I don't really care to go through it, but they're looking at linear regression and beta associations. And so some breast milk, whether it's exclusive or any human milk, is actually associated with a higher fat-free mass in preterm infants than in term infants. And I think that's really important to highlight breastfeeding or human milk supplementation for this population. And in fact, this shows the same. So any human milk versus exclusive human milk, you see the same association with fat-free mass. If we look at brain development, I think this is one that's really easy to sort of pick on. This was taken from Palumbi and BMC Pediatrics from just a couple of years ago. The expected IQ, right, because it's a normal distribution, is 100%, right? So if we look at mean total IQ for a population, you sort of hope that mirrors 100% if you're taking from the general population. But if you look at this population of 68 infants, again, there's obvious bias here, but the mean value was about 10 points lower than what was expected. And if you looked at them by breakdowns of what we consider to be normal IQ, which is basically a couple standard deviations within that 100, 63% fit there. We would sort of expect about 84, so I guess not quite 2 standard deviations. And then borderline IQ, about 20% versus just about 14%. But then what was really interesting was that the cognitive deficits, right? So the kids that are, pretty challenged, IQs less than 70, we were running about 15 to 20%, whereas we would expect that in the general population, this number would be about 2%. And then what that breaks down into is that a lot of these kids suffer from a multitude of different issues, whether it's speech and language disorders, specific learning disorders like difficulty with writing, reading, or mathematics. Attention deficit disorders, 25% almost, and then autism. Right? If you've read any literature, autism is related to prematurity for really unknown mechanisms, but that association has been described. What's also interesting is that if you look at large databases, you sort of get a similar rate of these things. So this was a group that looked at almost 1 million post-term kids, and then took about 40,000 late preterms, and then several other populations below 34 weeks. And you can see here that the rates of intellectual disability, and this was well defined at 7 years, this is school age, was 50 to 60% higher in the late preterm population than compared to the term population. Obviously, as you get smaller gestational ages or earlier deliveries, that number is much more apparent. But even in this population that we, like already said, is largely considered to look and act normal, you still get deficits in the population that are greater than their term counterparts. ADHD. So ADHD is a really interesting phenomenon that if you compare, and this group was about 60,000 kids. If you look at comparing to 40 weeks, which is sort of the ideal termination, right, the ideal end of pregnancy, what's interesting is that the 37 to 39 weekers look like they have a modest increase in ADHD risk. And probably the reason for that is that if you look at these error bars, they're pretty tight. And when you get to 37 and 39 weeks, particularly in large populations, everybody moves to the middle, right? There's not much variation. It's pretty rare for a 37 to 39 weeker to need to be admitted to the NICU, but you get more heterogeneity as you move lower in gestational age. So there's probably still an association, but it's a little bit harder to tease out because of the population is just so vastly different. But you can see here that even for girls, the association of gestational age at less than 34 weeks, there's a high association with ADHD. Boys, not so much, or at least not statistically identified. But again, the error bars are pretty broad there. So if we look at weight gain over time, remember I told you they lag with weight gain. So if we look at weight gain at between birth to 5 months, and then again from 5 to 20 months, and on the left side, my left side, growth in weight, and then on the right side, growth in head circumference, you can see that these growth metrics are very closely tied to things like IQ and executive functioning, right? Grade point average. These are all school-aged outcomes that we care very deeply about, right? So if you're born at 36 weeks and it doesn't cause any problems, okay, I mean, I can buy that. But it obviously is associated with poor school-age performance, right? So if we know that that is already associated with poor school-age performance, and then we have these weight gain or head circumference metrics that are lagging behind their term counterparts, well, then we may have additive risk. It may be an explanatory variable, but it also could be additive risk. So I think that it's important for our pediatric colleagues to understand that if you're born 34 to 37 weeks, that you're at risk. And so we have to pay very, very careful attention to these patients and make sure that they're growing well, that they're developing well, and that early intervention is outlined for them. The eye is actually a very interesting organ because it's strongly associated with prematurity. And so if you look at this, I thought this was a really interesting article looking at, roughly 1,500 controls born at term, and then another 115 kids that were born roughly late preterm, 32 to 36 weeks. If you look at just visual acuity, there's a 50% relative risk increase of visual impairment in the late preterm population compared to the term population. Amblyopia is much more common, strabismus, and then some of these others might or might not be associated with late preterm infants. And this does include, a moderate preterm population of 32 to 34 weeks, but you still get the same sense, right? So that vision, right, something that we rely very deeply on, may be impacted just by preterm birth alone. Again, very similar characteristics. If you look at, again, what I was highlighting was that it's often birth weight or it's often gestational age plus sort of a second hit, to sort of borrow from the cancer literature. You know, if you're born a little bit small and then you're born a little bit early, those things have additive risk, and I think this highlights that very well. So this is our perfect population, right? Term and normal birth weight, and then we compared slight preterm, and then normal term with low birth weight, and then sort of an additive risk of preterm and low birth weight. And you can see that this population is highly at risk for visual impairment, both just visual acuity, but also things like astigmatism, strabismus, amblyopia. These are other things that are pretty important for having normal vision. And if you can't see, then you often struggle with learning. So those things are closely tied together. Again, just the same thing. Another study showing the risk of strabismus is impacted by both being born early and being born low birth weight. So growing them well is important, but growing them to term gestation is equally important. Lungs. Okay, so I'm not talking about respiratory distress syndrome, although that's a key component of this. I'm not talking about intubation, et cetera. But if we look at like late-term outcomes like asthma or hospitalization for respiratory illness, there's now an astounding amount of work that shows that there's a correlation between late preterm infants and risk of later respiratory illness. So if you look at these studies, so this top one is hospitalization within the first 28 days for respiratory symptomatology. And this big black diamond is sort of the pooled descriptor of all these studies together. And you can see that because in this forest plot, that black diamond sits fully to the right of this sort of line of equipoise, then you know that there is a higher risk, or that it favors risk. And if you see down here, there's sort of a scale that shows you some suggestion of what that risk is. So maybe 2 to 3-fold increased risk. Similarly, within a year, still the diamond sits fully to the right of this line of equality. Even out to school age, 1 to 6 years, 5 to 12 years. One study showed that this persists even out to your almost teen years. And it may persist even out to adult years. You know, if you look at this bottom study, they're looking at 12 to 18-year-olds. If you look at a number of different types of admissions, so admissions for RSV bronchiolitis, this is a very common disease of infancy that causes hospitalization. You can see all these studies sit to the right. So late preterm infants, even out to 6 years of life, are much more at risk for being admitted for RSV or bronchiolitis, basically respiratory infections. To have asthma or some sort of recurrent wheezing episode, again, very similar associations with late preterm. And then what's really interesting is that if you keep tagging down here, you start to see that these things persist even for things like respiratory infections, so like pneumonia. You know, your odds of being admitted after a year of life or within the first year is higher for things like pneumonia. So it's not just about having reactive airway disease, it's about risk for infection. It's also risk for CNS disorder. So your likelihood of being admitted for things like, you know, I don't know, I won't even try to come up with some, but epilepsy, right? Mental disorders, right? Your risk for admission increases with late preterm birth. And so I think these important associations sort of highlight this population's risk patterns. This is another study that highlighted healthcare utilization, basically comparing late preterm infants to term infants, and they did, you know, univariate odds ratios and then adjusted odds ratios. And you can see, however they do it, there's a modest increase in risk of using more healthcare, of being admitted for asthma, and that persists even out to 7 years of life, so school age. This is a very interesting graph. It comes from a group out of Europe in 2016, and it shows the relationship between asthma and atopic dermatitis and gestational age. And so the reason these two are interesting is they're both considered to be atopic disease. Like asthma has a pretty significant allergic component. Atopic dermatitis, which is eczema, has a very strongly allergic component. And so if you look at atopic dermatitis compared to gestational age, there's really just a flat, you know, if anything, you could say there's an uptrend, if anything, that lower gestational age associates potentially with less atopic dermatitis or eczema. But asthma is not true, right? It's a very steep inverse correlation, so that the lower your gestational age, the higher your risk of having asthma disease later in life. So I think it's not just allergies. It's not just immune issues causing this. It actually is something to do with lung development. This is also sort of interesting. It's a Kaplan-Meier looking at term infants. So in the dotted line is term infants, in the solid line is late preterm infants, and it looks at cumulative incidence of wheezing episodes for these two populations out to about 8 years. And you can see that for the first year of life, they sort of mirror one another. But once they get past that first year, you start to see this dramatic difference between the two as far as incidence of wheezing. And you could make an argument that up to 30% of late preterm infants will have some sort of wheezing episode in the first 8 years. This is very similar. So they just did, sort of modeling to figure out what the associations were. And again, preterm birth, maybe a modest association, maybe underpowered for that, truly. Still smoking during pregnancy, again, you all know that that's a really important risk factor for a number of outcomes. So maternal smoking is a big one, and then history of asthma is another one that's really important. Sorry. Okay, sorry, we're trying to hurry up. And then if you look at gastrointestinal, so dysbiosis may also be a part of this. So if you look at the colonization of bacteria in the stool out to 6 months of life, they're starting to show that just late preterm infants have a different biosis in the stool, and we're starting to look at gut and brain and gut and heart and all these different associations with the gut that I think it's really important to sort of have some evidence to show why prematurity might associate with that. Maybe this is a possible scenario where you could describe a mechanism, but it's not well defined. It's still in its infancy stages. And then the heart. So the heart is strongly linked to prematurity or just cardiovascular disease in general. And so if you look at this in dark is early preterm, in the striped is late preterm, and then controls are in the white. And so if you look at like hypertension, the incidence of hypertension is much higher in early preterms, but it's still high in late preterms. Obesity, similar risk profile, metabolic syndrome, and then fatty liver disease, similar risk profile. If you look at the odds ratios, so hypertension on this study was not quite as strongly associated, but obesity, a very strong risk with late preterm infants and obesity, and then metabolic syndrome, which is that constellation of hypertriglyceridemia, obesity, insulin resistance, hypertension, et cetera. Again, cardiovascular risk. There's some relationship between prematurity, but it's not certainly well defined. You can see that some of these studies show associations with hypertension, others do not. And I think part of that has to do with when you're looking and the number of covariates that you try to account for, because hypertension is a multifaceted outcome that's not necessarily just related to preterm birth, but it is a risk factor, just like smoking, obesity, and hyperlipidemia. So here are the take-home points. Late preterm infants, this population of 34 to just under 37 weeks, I think is a population that really deserves a lot of attention because it's comprises 70% of all preterm births. It actually comprises 7% of all births, regardless of gestational age. There's a high neonatal and infant mortality, but there's also morbidity. Beyond the NICU admission, there's a risk for readmission, there's respiratory complications, visual disc complications, neurocognitive and autism complications. And then even if you make it through adolescence, right? So now we start to talk about cardiovascular disease, obesity, and metabolic syndrome. And I would remind you that the field of neonatology is relatively young compared to most fields of medicine. The first neonatologists were only trained in the early 70s. So we're really only seeing this population, the earliest preterm infants are probably 50 years old. So we're just now seeing that population get close to sort of midlife, start to approach retirement when a lot of these morbidities will start to show. And I think we have a pending epidemic that's going to arise that I think we can hopefully make generational change if we could just skew the data a little bit in our favor for delivery. And so with that, I think we are being kicked out of here. So I will I will sort of forego questions if that's okay. If someone has questions, they're welcome to email me, and I can answer them just directly one-on-one. All right, thanks, Chad. I appreciate it.
Thank you. That was great.
Brian?